We've reached chapter 34, which is multi-system trauma. Some of the goals here, how to balance the critical trauma patient's need for prompt transport against the time that they need to treat all of those patient injuries at the scene. And then also how to determine the severity of the trauma patient's condition, their priority for transport, and the appropriate transport destination. We're going to try to figure out how to select the critical interventions to implement at the scene for the multi-trauma patient, and then how to calculate trauma score, which is another method of really trying to figure out the severity of what's going on using three different pieces of information that you've already learned about. So the multi-system trauma is going to be that trauma that is a little bit more significant for the patient. It's not going to be isolated to just one area. There's going to be different systems of the body all involved with this, and it's going to test your assessment skills. It's a short chapter, not a whole lot of slides, so it shouldn't be real long, and we'll plug our way through this. So with the multi-system trauma, like we said, this is going to be when there's more than one serious injury. So they're going to have multiple trauma sites on their body that you have to assess. It's important not to get caught up on the goriest injury because it's going to be the one that catches your eye, but it may not be the most serious one. So use your assessment skills. Make sure to start with that primary survey and identify any life-threatening conditions, and then go from there. Multi-system trauma patients are going to have one or more injuries serious enough to affect more than one body system. So think of a gunshot wound that passes through the chest and the abdominal cavity. You're going to have many different organ systems that would be involved in that. So this would be the multi-system trauma. You're also going to see multi-system traumas commonly in motor vehicle accidents, pedestrian accidents, any place where you have a high mechanism of injury, you're going to have a high suspicion of multi-system trauma. What's important with multi-system trauma is the teamwork, because you're going to need to get them extricated, moved. There's going to be multiple areas that you're assessing, that you're treating, and if you have a good team, you can get this done much more prompt than if you just have to do things by yourself. The timing of everything and then the transport decisions are also key to the proper management. You want to make sure to try to keep your scene times to a minimum, and you want to make sure to get these patients to the appropriate destination so that they can be properly cared for. Some of the first critical decisions that you're going to have to make are going to be determine that patient's priority severity. So you need to utilize that primary survey initial assessment so that you can determine the significance of the injuries, the severity of the injuries, so that you can determine what their priority level is. If this is going to be a load and go, or if this is going to be something you can stay on scene, if this is something that you might need ALS for, or maybe you even need aeromedical with the helicopter to transport. These are all important decisions, but these are all decisions that you need to make very early on in the call. And some of these decisions you can even kind of get in motion before you get to the patient. If you suspect that it could be a multi-system trauma with a high mechanism of injury potential, then it's something that you might want to put the helicopter on standby, perhaps even have the helicopter launch so that they're heading towards you, perhaps calling ALS and having them start heading towards your direction. You can always cancel them, but if you start them early, then those 3 or 4 minutes could be critical in the patient's survival. Now, the CDC has developed some basic algorithms basically that help you from a physiological standpoint to determine that severity of the patient's condition. So anytime that you have these three conditions, you need to be thinking a higher level of suspicion of it being a significant injury, where you need to start thinking limiting scene time, load and go, aeromedical, whatever the case may be. And these three things are going to be the altered mental status, which is a GCS of less than 14, which may indicate a head injury. Hypotension with a blood pressure systolically of below 90, and that is going to perhaps indicate shock or internal bleeding. And then abnormal respiratory rates, which could indicate a head injury or later stages of shock. So anytime that you have one or more of these three situations, it's going to be a little bit more critical situation in which you need to think load and go. There's also going to be some anatomic criteria that is going to should at least put your brain in motion that this is going to be a severe call. These things are going to be not limited to just this list, but these are kind of the four main things that you'll be looking for, and that's amputation proximal to the wrist or ankle. So anything above the wrist or ankle, that's an amputation. Any pelvic fractures, any open or depressed skull fractures, and then any type of paralysis. If you have any of these four conditions, again, think critical, think load and go. I know in the state of Illinois, they have trauma alert criteria, and most of what they're covering through these few slides are included in that trauma alert criteria. So you may have other resources to help you make these determinations as well. Some more criteria from the anatomic standpoint: any penetrating injuries to the head, neck, torso, and extremities proximal to the elbow or knee. So basically anything above the elbow or above the knee to any other portion of the body, if it's a penetrating injury, should raise your level of severity. Any chest wall instability or deformity. We've covered that in previous chapters with what the underlying circumstances could be as far as the severity of the condition that's going on with the patient. 2 or more proximal long bone fractures. So if they have bilateral broken femurs, or if they have a broken femur, broken humerus, those would be indications as well. And then any crushed, degloving, mangled, or pulseless extremities. So any major trauma to the extremities are another situation which should raise your level of severity. Let's say that your patient hasn't met the physiologic criteria or the anatomic criteria. The next thing that we need to look at is going to be the mechanism of injury. So if there is a severe, significant mechanism of injury, then it's also going to raise your level of suspicion of it being potential severe injuries to the patient. So any falls of a significant height, any high-risk auto crashes, which would include intrusion, generally speaking, intrusion of greater than 12 inches into the passenger compartment. With the newer cars today, they're really made to take a beating. So you may have the whole front end completely destroyed, and the passenger compartment stays fully intact. That's kind of how they're built. So when you're thinking of intrusion, it's not just big dents and smashed up outer portions of the car. You're looking for intrusion into that passenger compartment that could potentially injure your patient. Anytime you have an ejection from an automobile, anytime there's death in the same passenger compartment. So if you have 3 people riding in the vehicle, one of them has died, even if the other 2 seem perfectly fine, and they may be perfectly fine, it should still raise your level of suspicion. And then a lot of the newer vehicles also have the ability to transmit data on how severe the crash was. So if they've got this vehicle telemetry data that would be consistent with a high-risk injury, then that's also another area where you raise your level of suspicion. The last consideration that we're going to have when determining severity is going to be some special circumstances with patients in consideration. So older adults, when you go back to the shock chapter, we talked about how they don't efficiently compensate for shock. So with older adults, it should raise your level of suspicion with severity. Children may benefit by being transported to a pediatric specialty facility if there's one available. I know where we are, there's not really a children's facility within reason. So one thing that you can think of if the patient has stable vital signs is this would be a good place to use the helicopter, because they may bypass the local facilities to get them to a pediatric center. Otherwise, what you do is you transport them to any of your local facilities, and they'll stabilize them, and then they'll have the helicopter or ground ambulance transfer them down to a pediatric specialty. Other patients that you need to have some special consideration to are if they're taking any sort of blood thinners, and then patients, any woman that's pregnant. Those are two more areas of consideration when determining the severity. So looking at this from the standpoint of being a typical call, some things that you're going to have to ask yourself. First one being, when do you recognize that the patient has multiple injuries? Hopefully that's going to only take a few seconds very early on in your primary assessment to recognize this. And as soon as you recognize this, then you need to start going into this multi-system trauma thought pattern. What body systems would the EMT suspect have been affected by the patient's injuries? So again, you need to take into consideration what the body systems are that could potentially be injured, and the severity of those injuries when you're starting to make some of these considerations. Next thing to think about is, what is the EMT's first decision about managing those injuries, and why would you make those? So, are you thinking this is a load and go? Are you thinking that you need to stabilize? Are you thinking you need ALS? These are all considerations that you have to take into play with this. Next would be, what actions would you take to support the body system? So what are you going to do to try to correct the issues and stabilize this patient? And then finally, what priorities would you set for this patient? Are they critical? Are they needing helicopter transport? Are they needing a specialty facility? What is your thought process for your transport determination? So we're going to take a few slides here and look at the general principles of the multi-system trauma. So first, and this can happen before you even get to the scene, is to determine the roles of a multi-system trauma patient beforehand. So if it's you and your partner, and say you have fire department responding for a car accident, hopefully the fire department's role is going to be extrication and getting the patient to you. And then you and your partner to determine what your roles are going to be. One of them might be doing a rapid trauma assessment, while one of you is managing the airway. Regardless of what you determine your roles are before you get there, it's a dynamic situation. So it can be ever changing depending on what you find and determine necessary treatment as you work your way through the assessment process. So most importantly, follow the priorities that are determined by your primary assessment. I mean, we've talked about this 100 times throughout all the chapters. Primary assessment, ABCs, immediate life threats. Those are going to be the most important things that you need to focus on. Don't get tunnel vision. Don't get caught up in the blood and gore, especially when it may be something that's not life-threatening. Another consideration that you need to have is remembering what's called the golden hour. And that's the need for critical trauma patients to get to surgery within 1 hour of the injury. Not 1 hour from when you get there. If you're 10 minutes from the time the accident happened till the time you got on scene, now you have 50 minutes to basically Do what you need to do, load them up, transport them to the hospital, let them be evaluated in the ER, and hopefully have an OR team ready to take them if that's what the case may be. With these patients, you do want to somewhat limit your scene treatment if at all possible. And basically, you're limiting your scene treatment to life-threatening conditions that you need to correct. So things like stabilizing the cervical spine is going to be very important to potentially prevent death, prevent paralysis. As we talked about in the previous chapter, there's a lot going on with that cervical spine stabilization. Airway, ABCs, again in the primary survey. So suctioning the airway, inserting OPAs, NPAs, restoring a patent airway, ventilating them with the bag valve mask, administering high flow O2. So airway, 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 and then control bleeding and restrict that spinal immobilization. Continuing here, and probably should have been listed first, but scene safety is paramount. You can't take care of the patient if you're part of the problem. So make sure that the scene is safe. Make sure that you can appropriately get to the patient or the patient is brought to you. Ensure that the patient has an open airway, again back to the primary survey. Perform those urgent or emergency moves as necessary. And we talked about this way back in the lifting and moving chapter, that sometimes you have to put life over limb. Sometimes, depending on the situation, you may have to perform one of these urgent or emergency moves. And then adapt to the situation. Know that things change. Understand that the patient's condition may also change. So it's a evolving situation that you have to be ready to adapt for. A couple things to consider with pediatric patients is that A, they're going to be young, they're not going to understand what's going on. They're not going to understand any of the technical jargon. So speak in common sense to these patients and common language to these patients. Make sure that you're communicating with them. They're going to need that additional emotional support. It's going to be a very scary situation for them. So you need to be reassuring, honest, and realistic with them. And then as far as spinal motion restriction is considered, follow your protocols and add consideration of the mechanism of injury. Like we've talked about, not all patients need to have full spinal immobilization anymore, and it can be a very scary situation for a pediatric patient to be completely locked down to a backboard. So if you absolutely don't need to, it's one thing to consider. Now we have a few slides that are going to talk about the trauma scoring system. So, we've had other scoring systems, and you'll have at least one more coming up with newborns in the APGAR scoring system, but you've had the Glasgow scoring system previous that we've talked about. Now we have the trauma scoring system, and this is going to help you determine kind of the severity of the trauma and help you make some decisions. So it's a numerical rating system. So it's going to be 12 is going to be the perfect score. It's going to assign a number based on certain patient characteristics, and it's going to objectively describe the severity of what's going on. So the lower the number, the more severe it's going to be. It's going to help you determine to transport to a trauma center or just a regular local hospital. And then it helps trauma centers evaluate the care of similar patients, and it's going to kind of give them an idea of what you're bringing into them. The components that this revised trauma score is going to use are going to be the Glasgow Coma Scale, the systolic blood pressure, and the respiratory rate. And each of those three categories can have a maximum score of 4. And on the next slide, it's going to break down what each of those categories are and then how you assign a number to each of those categories. You're going to want to follow the local protocols whenever you use the trauma scoring system, but don't let it interfere with your patient care. It's not like this is the first thing that you have to do, but it is kind of an important aspect from the trauma standpoint, just to gauge severity. And that means that we've concluded the Chapter 34 lecture. And like I said, it's a short one because it's really taking all of the other trauma chapters and just saying, okay, what happens if you have injuries and issues from different areas of these chapters and they all combine on the same patient? How do you treat it? So what's your thought process for multi-system trauma? Now with this, we'll be finishing up the unit and we'll get the rest of the information put up and the PowerPoint put up. We've got one more chapter to do that falls in the trauma category, and that's the environmental emergencies. We'll get through that, and then it'll move over out of the trauma section and into really the last few chapters for you guys. So if you have any questions, make sure to let us know.